Our next chapter is pulmonary thromboembolism, and the first case that we're going to do is a 32-year-old woman who comes to the emergency department with acute shortness of breath and pleuritic chest pain. She takes only oral contraceptives and has no significant past medical history. Her respiratory rate is 26. That's increased, of course. Her pulse is elevated. That's increased. Her lung and heart exam are unremarkable. And look at this. You do an ABG in her. It shows respiratory alkalosis. Now, she's hypoxemic, right? And you look at 70, that's hypoxemic. But then you also do the AA gradient, and then you figure out that her AA gradient is 150 minus 1.25, right, times 25. So figure, let's say that's about 30, so 150 minus 30, and then you subtract 70 from that. The PaO2 here, right, is 70. So figure her AA gradient is about 50, maybe a little bit more than that. I just did a gross estimate of that, but it's definitely elevated. And look at this. Despite all this, the shortness of breath and stuff like that, and the normal physical exam, the big AA gradient, you do a chest x-ray, and this is unremarkable. And then you have to think about thromboembolic disease in this patient, because you can't find a reason for her shortness of breath, her hypoxemia, her AA gradient. The exam is normal, the chest x-ray is normal, and she also is a high-risk patient. She's a high-risk patient because she takes oral contraceptives, and the oral contraceptives have been shown that they are associated with increasing thromboembolism in patients. So let's talk about this disease, and then we'll go back and talk about certain cases. Let's talk about some general concepts about thromboembolism. We now know that the clinical important pulmonary emboli are associated with a proximal DVT. So a proximal DVT and pulmonary embolism is one and the same disease. That's the way you think about it, because most of the pulmonary emboli arise from the proximal DVTs. They dislodge, they go onto the right side of the heart, they break up, and they go into the lung and cause pulmonary emboli. There's other causes of pulmonary emboli, but in about 80–90% of the cases, it comes from a proximal DVT. And I want you to know that one and the other are one and the same disease. Now, they've also looked at this in a different way in people with DVT, and they've done VQ scans. We're going to talk about VQ scans a little bit. Now, these are patients that have no symptoms from the lung, but they presented with proximal DVTs, leg swelling, and they did VQ scans on these patients, and 60% of them have high probability VQ scans. So a lot of these patients have had pulmonary embolism that's asymptomatic already from the DVT. I want you to think about these two diseases as one disease. Not distal DVTs. The clinically important PEs are associated with proximal DVTs. Well, where do the proximal DVTs come from? And the answer is they come from distal DVTs. That's where most lower extremity clots start from. They start from the distal extremity below the knee, but nothing happens to those there by themselves. Nothing. They don't dislodge. They don't go into the lung. What happens is the distal DVTs, they propagate above the knee into the proximal veins, and then that is when they become clinically significant, and those are the ones that break off and they cause the pulmonary embolism and so forth. So there's some exceptions to this whole concept. Yes, there are, and there's two very important ones that we see in clinical practice. One is pregnancy-related DVTs. Patients that are pregnant that develop thromboembolic disease sometimes develop clots in their abdominal veins. That's where there's obstruction, and that's where they develop the DVT. So it's above the proximal veins of the thigh into the abdominal vessel. So in pregnant patients, that's one area to look for and exclude abdominal DVTs as a cause of pulmonary embolism. And then in certain patients that we see now, because we send people home with central lines, because we have a lot of dialysis patients, because now we get the patients quickly out of the hospital and send them home on antibiotics with central lines in the upper extremities, in the subclavian area, in the IJ and so forth. We see a big rise now in upper extremity DVTs. And upper extremity DVTs present with arm swelling and shoulder pain and stuff like that. They're not as associated as the proximal DVTs. They're not common to cause pulmonary emboli, but there are cases of pulmonary embolism from those, so you have to suspect them if the patient gets short of breath and so forth. So most cases, I repeat, of pulmonary emboli arise from the proximal DVTs. The exceptions, the two exceptions to the above, is the pregnancy-related DVT and the upper extremity DVT. We usually have a history of pregnancy in one case, and then in the other case of some kind of central line involving the upper extremity or something like that. Most cases of proximal DVT go into the right side of the heart and then break off and go into the lung. But there's also cases of what is called paradoxical embolism, where because a patient has patent foramen ovale, the clot, instead of going into the lung when it's in the right side of the heart, goes through the patent foramen ovale into the left side of the heart and then causes systemic embolization. Systemic, I mean in the arteries. So theoretically and clinically we see this. A patient with a DVT can sometimes have embolic stroke, systemic embolization, and stroke from a proximal DVT with this thing called the paradoxical thromboembolism. This usually occurs when a clot already has gone into the lung, raising the pulmonary pressures, very high pulmonary pressures. Because these pressures increase, when you get a second clot going into the right side of the heart, instead of going into the lung, the pressures are high, so it goes into the patent foramen ovale and then the systemic circulation. So you may hear about paradoxical thromboembolism, as a clinical event. It's very interesting, through the patent foramen ovale. The way we treat proximal DVTs is the same as pulmonary embolism, because I just told you that one and the other is about the same disease. So when you find a patient with a proximal DVT, you should treat it just like a pulmonary embolism. 6 months of anticoagulation, if not more. Be careful, because the proximal veins, we're talking about the deep veins, right? The deep veins. The superficial femoral vein is part of the deep veins. If they tell you that a patient has superficial femoral vein clot, superficial femoral vein clot, that is part of the deep venous circulation, and that is a proximal DVT, and it commonly causes pulmonary embolism. All the other superficial veins are usually not associated with pulmonary embolism, right? You don't have superficial thrombophlebitis causing pulmonary embolism. It's very, very rare. It's only the deep veins. But be careful about that superficial femoral vein, because they kind of sometimes trying to trick us thinking that this is a superficial vein. So the natural course of a lower extremity DVT, we said, starts off as a distal DVT. It goes into the proximal veins, this propagates, and then at some point may break off and go into the right side of the heart, into the pulmonary vessels, and cause a pulmonary embolism. And then sometimes the patient never has a second chance. They die from a massive pulmonary embolism, the first one. Kills a lot of these patients. When the patient comes with shortness of breath, it means that they have survived the first pulmonary embolism. You got to prevent the second one so it doesn't kill them. Well, the first thing that we think about, that we should think about when we think about thromboembolic disease, is which are the high-risk patients, because these are the ones that really clue us into should we think about thromboembolic disease. And the high-risk patients are usually people with recent surgery, especially orthopedic surgery, especially look for knee replacement, hip surgery. Please be careful. Those are probably the highest risk patients that you're going to see. Then the second category are patients with cancer. We know now that patients that have cancers, even undiagnosed cancers are high risk for thromboembolic disease. They're hypercoagulable. Something that the cancers secrete, things like prostate cancer secrete maybe tumor necrosis factor. Something happens to these patients. They become hypercoagulable. A study which has been repeated in about 6-7 years ago, and the first one was done maybe about 10 years ago, showed that in people with proximal DVTs of no reason to have them, when they were followed in time, so they took unexplained DVTs in patients and they followed them in time, up to 2 years, another maybe 15–20% of these patients developed cancer. So what really had happened is these patients had cancer before, and the thromboembolic disease was a manifestation of the hypercoagulable state associated with cancer. So please, patients that have unexplained thromboembolism, you don't have to scan them up and down looking for cancer, but make sure they've done the age-appropriate screening. Breast, colon cancer, prostate, and so forth, so you don't miss something like that. Immobility is a big deal. So they tell you about the patient that has been lying in bed all their life because of a stroke, or they've been in the hospital for a long time and because of some other sickness. These patients are there. Once you have stasis, right, that is a big part of thromboembolism. And then we know people in airplanes, because it seems to be the immobility, right? They sit in the, and they've shown this in studies, that the people that are left and right that can move right in the seats don't get thromboembolism. It's the people in the economy class, especially the people sitting right in the middle. You know, they can't move left, they can't move right, and the stasis, especially in people with predisposed conditions, the stasis in the airplane, long airplane flight, predisposes them to clot formation and thromboembolism. Acquired thrombophilia is a very interesting condition where these patients get a form of hypercoagulability, and they're not born with it, but they get it, either because they have some kind of autoimmune disease, or they get nephrotic syndrome and they lose antithrombin 3, or they take oral contraceptives and the oral contraceptives does something to their protein C and so forth. The three ones that you have to know is the lupus anticoagulant, or the antiphospholipid antibody syndrome. That's another name for that. Sometimes we see it in patients with lupus, and these patients are hypercoagulable. And then nephrotic syndrome is very interesting, because in nephrotic syndrome you lose a lot of albumin. And antithrombin 3 is about the size of albumin, and these patients lose antithrombin 3, so they have an acquired antithrombin 3 deficiency, and they're hypercoagulable. Now remember, we need 3 proteins to basically keep our blood anticoagulated, right? Protein C, protein S, and antithrombin 3. Those are the 3 ones, and if we lose one of those, we become hypercoagulable. And that's what happens in nephrotic syndrome. The interesting thing about nephrotic syndrome is, you know, it involves the kidney, and these patients commonly get thrombosis of the renal arteries. Renal artery thrombosis, that's what they get. Sometimes they get renal vein thrombosis too, but the one that I want you to remember, renal vasculature thrombosis associated with nephrotic syndrome and acquired antithrombin 3 deficiency. And we talked about oral contraceptives. The oral contraceptives are very interesting. The older ones were probably more hypercoagulable than the ones that we have now, just because they're using a lower dose of oral contraceptives. But they are especially, they are high risk, especially in patients that smoke at the same time, they use tobacco. So these patients are even higher a risk for hypercoagulability and thrombosis. And then we have the inherited thrombophilias. This is another interesting group of diseases. We're going to talk about factor V Leiden a little bit later. The most important one, this occurs in people of usually European descent, where you need factor V Leiden to activate your protein C. And if you don't have, if you have a mutation in your factor V Leiden, you can't activate your protein C. And now you really have enough protein C, but it's not activated, so you have a qualitative deficiency in protein C. This is sometimes referred to as protein C resistance, where you can't develop activated protein C because of this mutation with factor V Leiden. That's what this is called. It's probably the most common inherited thrombophilia. You're going to hear a lot about this disease over the next couple of years because people are finding out that in certain areas in Europe, 10% of the population may have some part of factor V Leiden, maybe heterozygous to factor V Leiden mutation. And then we talked about pregnancy as a high risk in patients because of the stasis, because pregnancy also does some other things to protein C and so forth that we're going to talk about. So high-risk patients, the right clinical scenario, high-risk patients is the second thing we look for, and that's when we start to thinking about thromboembolism. So the consistent symptoms are sudden onset of dyspnea, just like our patient had, thigh or calf swelling along with the sudden onset of dyspnea, or thigh or calf swelling by itself, and then pleuritic chest pain. The patient says, I can't, when I take a deep breath, my chest wall hurts, I can't take a deep breath, it hurts me. And then hemoptysis, when there's in somebody that has never had any history of lung disease. You always think about thromboembolism. Now, you don't always get hemoptysis with thromboembolism. You have to have really an infarct, and that's rare. The infarct is rare because you have dual circulation usually in the lung, but sometimes you get it. And then especially you have to think about when somebody's at risk for thromboembolism and they develop all of a sudden hemoptysis, you have to think about it. Always look at the vitals when you're thinking about thromboembolism. Always look at them because they've done studies, and even though having a high respiratory rate and an elevated pulse, tachypnea and tachycardia is not specific for any disease. We see them in 150 diseases. It is the most sensitive two tests in people with pulmonary embolism. So what does sensitive mean? That all these patients have tachypnea and they have tachycardia. And if they don't, you should probably think less of these diseases and look for something else. They always have an elevated respiratory rate. They always have tachycardia. The respiratory rate may be 20, but that's not normal. Remember we said 12 to 14 is normal. It's always elevated. 20, 22, 24, 30. It's always elevated. What do we do? How do we do a workup of a patient with thromboembolic disease? Well, there's a couple of general tests that we start off with. The first general test to start off with is the ABG. And the typical ABG, we find hypoxemia with an increased AA gradient, just like the patient that we saw before. Now, the ABG, some people tell me, yes, you have to have an AA gradient on the ABG and you have to have hypoxemia. But no, I'm telling you here that normal, it may be normal or near normal in healthy young patients. So young patients, they have a lot of, they have a lot of normal lung, so they're able to adapt. And sometimes the ABG in these patients, despite pulmonary embolism, is normal or near normal. So the ABG, when you have a high AA gradient and hypoxemia and no cause for it, you got to think about thromboembolism. But if you're thinking about thromboembolism, you can't exclude thromboembolism with a normal ABG. Please be careful of that. The chest X-ray, most of the time is normal because usually the pulmonary embolus doesn't do much, right? Sometimes you may have a small effusion if you have an infarct, and I've told you when we were talking about effusions that this could be a transudate or an exudate. A pulmonary embolism could cause a transudate or an exudate. It's one of the few diseases that could cause both a transudate and an exudate. And then some very interesting other things that they don't ask us a lot about, but it's good to know, a Westermarck sign and a Hampton's hump, right, where one, you have a cutoff on the normal, not on the normal chest X-ray, but on the regular chest X-ray, you had a cutoff of the vessels because of the pulmonary embolism, and you could see that rarely on the chest X-ray. And then sometimes you see the elevation of the hemidiaphragm because of the pulmonary thromboembolism that you see. It looks like an elevation there that is consistent with the infarct there. The electrocardiogram most of the times is nonspecific. It only shows sinus tachycardia, but sometimes you may show the typical right-sided heart strain with these deep S1 waves S waves in the 1 lead, the deep Q waves in 3, and the irregular T waves on 3 also. So the mnemonic for that is S1, Q3, T3 to remember the changes associated with thromboembolic disease. But the most common finding that we see is basically nonspecific sinus tachycardia. After you do all the nonspecific tests, now nonspecific, I mean these are the tests that usually get done on the emergency department as soon as the patient hits there, or the office, and everybody gets these tests. So I mean nonspecific because they're easy to do, and then you decide, you know, what are my risks for thromboembolism in this case, and then you go after this and you start to think about more specific tests to do, and really diagnose the disease by either direct visualization or tests that have indirect visualization but are more specific. So right now, as we're speaking, probably the most specific test to do, probably the first option, is probably a spiral CAT scan. A spiral CAT scan visualizes the pulmonary circulation better than any other test. This is not a high-resolution CAT scan, right? This is different. It's a spiral CAT scan. It shows cuts of the pulmonary vasculature, and it allows direct visualization of the pulmonary embolism. Now, the older tests that we used to do, like the VQ scan, right, were allowed indirect visualization, so they weren't as good. This allows direct visualization, and then it gives you also, if you don't find pulmonary embolism, it also gives you some alternative diagnoses for the disease. For example, maybe I won't find pulmonary embolism, but what I will find is I find an infiltrate that I didn't see on the normal chest x-ray because it's non-specific. You know, it's not specific enough to pick up a pneumonia, and I'll find the infiltrate there, and I say, hey, this guy doesn't have pulmonary embolism, but this CAT scan shows me that they have a pulmonary infiltrate. This is consistent why he or she is short of breath. So the spiral CAT scan is a great test to start off with. It's the way most people start off with now in evaluating people with thromboembolism, because it allows direct visualization of the pulmonary embolus, and it also, when it doesn't find it, allows alternative diagnosis. The shortcomings are that it may sometimes miss peripheral, small pulmonary emboli. So if a pulmonary emboli occurs in the periphery of the lung, not central pulmonary emboli, the spiral CAT scan could miss it. And nobody knows what is the clinical significance of these peripheral pulmonary emboli. Do they propagate? Do they get worse? Do they do anything to the patient? Nobody knows. Nobody has evaluated that. Right now, the spiral CAT scan is undergoing a big study at the NIH. This is the PIOPED-2 study, and so far, all the results that have come out seem to be that it's not a 100% test because it misses the peripheral P, but it's definitely a good test, if not the best test to start off with in evaluating thromboembolic disease. So you're going to be hearing more and more about that, the PIOPED-2 study, as all these patients now have been evaluated with a spiral CAT scan, and then a lot of these patients, they do angiogram or follow them up. So we know what it means to do a spiral CAT scan, how sensitive and specific it is now, and it seems that it's pretty good. So for right now, this is the first test to do when you're thinking about pulmonary embolic disease. Now, some of the other tests that we were doing in the past is the ventilation perfusion scan. Now, the ventilation perfusion scan is a good test. Now, it's more cumbersome. You have to do a ventilation part and then a perfusion part. So, or start off with a perfusion part and then do a ventilation part. So, and these tests, the problem is that you have to do two parts to this test. And remember, pulmonary thromboembolism is a perfusion defect. There's a clot in the pulmonary circulation, so there's a perfusion defect. And so at least the perfusion scan should be positive. It should show some cutoffs there, some perfusion defects, and then at the same time, ventilation should be normal. So this is called a ventilation perfusion mismatch. That's the typical finding on the VQ scan that shows pulmonary embolism. And if you remember the natural course of the disease, I told you that the pulmonary embolus goes into the right side of the heart and it breaks off, it goes into the lung tissue. Then you get multiple pulmonary emboli there. So on the ventilation perfusion scan, you should have multiple defects. The more defects you have, the more likely it is to have pulmonary embolism. Now the problem with the ventilation perfusion scan is not only is it cumbersome, but they don't give you an exact visualization of the embolism, and you don't have alternative diagnosis. And then the way that they read these scans is that they give you a probability. So for example, high probability means that this patient 90% of the time has a pulmonary embolism. Intermediate probability means that 50-50, flip of a coin. Low probability means that it's really low, it's about 10%, but it's still significant, because somebody with, pulmonary thromboembolism 10% of the time, could have pulmonary thromboembolism and die from it. But I will tell you, I will tell you two things that you have to know. They won't ask you much about the VQ scan. They may ask one of two things though, and here it is. If you have a totally normal perfusion scan, the perfusion scan is the first one that they do, and if that is totally normal, then they won't have to do the ventilation scan, because if a perfusion scan is normal, it means that, well, what am I looking for in the ventilation scan? There's no reason to do it. If a perfusion scan is totally normal, not low probability, but totally normal, the chance for pulmonary embolism is virtually zero. It's almost as good as an angiogram. So I want you to remember that. Second of all, I want you to remember another reason why we don't like to do the ventilation perfusion scan. Because if a patient has pre-existing lung disease, so they have a ventilation problem already, like COPD, let's say, or some kind of interstitial lung disease. They have a lung disease already. These patients would have minimum an intermediate scan. The reason is because the lung, in certain areas where there's lung damage in the parenchyma, there's ventilation defects there. It doesn't perfuse these areas in the same area, just basically so it could shunt blood to the other areas of the lung. So these areas, even though they don't have a perfusion defect, will develop perfusion defects on the perfusion scan because they shunt blood to different areas. So the bottom line, anybody with pre-existing lung disease, very difficult to make a diagnosis with a VQ scan, because it's going to be minimum intermediate no matter what, right away. So for these reasons, we go straight to a CAT scan now. That's the most important test to do. If they ask you, what's the gold standard? What if you're still worried, even though the CAT scan was negative or whatever? Is there a gold standard test to do? And the answer, yes, it's the angiogram. It's an invasive procedure, right? And there have been deaths in the past because of the angiogram. But now they do it with soft tip catheters, and people are really good with them. The mortality and morbidity is way less than 1%. So in good medical centers, the angiogram is a very safe procedure to do right now, right? And when there's a question, does this patient still have pulmonary thromboembolism, even if all the other tests are normal, then you should go to the angiogram and make sure you exclude it or diagnose it. So start off with a VQ scan, and then, start off with a spiral CAT scan, and then if there's still any questions about anything, maybe you're missing peripheral pulmonary emboli, think about maybe doing the angiogram and making the confirmatory study. A couple of other things that we need to know about. Other testing that helps out. Some people say, wait a second, before they go into the angiogram, is there any other test that I could do that's non-invasive, that maybe I can make my diagnosis? And the answer is yeah. Remember, where do pulmonary emboli arise from? They arise from the proximal vein in the distal extremities. So some people say, listen, okay, my CAT scan is negative, but I'm still thinking that this patient may have pulmonary thromboembolic disease. Let me do a Doppler ultrasound to look for DVTs, compression Doppler ultrasound, to look for DVTs, and if that's positive, well, now I have my answer. If it's positive, then this patient has thromboembolism and you treat it. If it's negative and you're still thinking about it, then you may want to do the angiogram. So there are other tests to do that are non-invasive. And there's also these two tests here, the venogram and the MRI. These are tests specific for DVT. These are tests to do when your Doppler or compression ultrasound, your duplex ultrasound, doesn't give you the answer. They should be reserved only when we're looking for DVTs, really, in the evaluation of DVTs. In pulmonary embolism, when the patient comes with symptoms and signs of pulmonary embolism, we should go where the money is, in the lung, and then use the Doppler ultrasound only if we don't have an answer there. So, for example, like I said, a negative CAT scan, you may decide to do a compression ultrasound to see if the patient has a clot in the proximal veins before you do the invasive procedure. So that's the compression or duplex ultrasound, how we use it in thromboembolic disease. And now a couple of other tests that have come about in the last couple of years that are very important, and they're going to be probably more important as time goes by. And this is the D-dimer. Now the D-dimer is not a specific test, but if people said, well, wait a second, if you have clot formation, right, and you know, clot formation and clot breakdown from either thromboembolic disease in the veins or thromboembolic disease in the lung, you should have an increase in fibrin degradation products and D-dimers and stuff like that. These are all products from the clot, the breakdown and regeneration of a clot, and that's what we measure. We try to look for some kind of clot, right, either in the legs or the lung when we measure D-dimers. Now D-dimers could be elevated in chronic disease, they could be elevated in something else. So they're not specific for any thromboembolic disease, they're only sensitive meaning that if it's negative, you could be pretty much sure, if the D-dimer is negative, that this patient doesn't have thromboembolism. So how do we use it? We use it only in low-risk patients, and we use it usually in the emergency room so we could send these patients home quickly, low risk. And you say, okay, let me do a D-dimer. If that's negative, I got a low-risk patient, I'm pretty sure now that I could send this patient home without any questions, without doing anything more. Some people will say, okay, just to be 100% sure, I'll do a spiral CAT scan too. So for your purpose, a spiral CAT scan negative along with a D-dimer negative excludes thromboembolic disease. I'm going to tell you a little bit about the different ways to use these tests a little bit later. The test to do when we do the D-dimer is the ELISA test. There's different types of D-dimers. They're not all sensitive, and they're not all as sensitive, so they're not all as good. The test to do is the ELISA test. That's the most sensitive test, the best test to do when you're looking for thromboembolic disease. So the D-dimer right now, you're going to hear people doing it in the EDs. They do it really quick in low-risk patients so they can get the patient home really quick. So let's do some possible diagnostic concepts here. So we're thinking about a patient with thromboembolic disease, right? What do we do first? We always start anticoagulation. Please, especially a patient that has respiratory complaints and is hypoxemic, please don't send this patient off to any X-ray machines or any diagnostic imaging without starting anticoagulation. Unless they have a contraindication for anticoagulation, please start them on heparin or low molecular weight heparin, either one. I don't care. They both work equally well. Probably low molecular weight heparin is better because the risks of bleeding are less. So please start that patient on anticoagulation before you send them off to the spiral CAT scan or you send them off to the VQ scan or something like that. Start with a spiral CAT scan. I said right now, most of the people, 90%, when you're thinking about pulmonary thromboembolism, you start with a spiral CAT scan. they tell us that it's positive for PE. That is true. That is a true positive 100% of the time. If you visualize a spiral CAT scan and it's positive for PE, it's positive PE. There's nothing else. You treat it and you go no further. You treat it for pulmonary embolism. If it's negative, then you consider maybe still the possibility, if you can't find the explanation for anything, about peripheral PEs. Remember I said the CAT scan could miss peripheral PEs. So that's still a possibility. So if you're worried about the patient, you can't find an alternative diagnosis, the x-ray is normal, think about this. What do you do now? Well, there's a couple of other possibilities. One thing is to do a Doppler ultrasound. See, maybe you could find the clot here. Another possibility is, if the Doppler ultrasound is negative, is to go and do the angiogram. So that's one pathway. Then another possibility is to do a D-dimer and see if that's normal. So a normal CAT scan plus a normal D-dimer, especially in low-risk individuals, no pulmonary emboli. Some other people that don't have access to CAT scans will do a D-dimer along with the ultrasound. This is in people presenting with low extremity edema. So you're thinking about DVTs, right? And you're saying, okay, if they don't have a clot here, right, the D-dimer is normal. They likely don't have a clot here either because the D-dimer is normal. I can send these patients home. But please be careful, right? These should be only low-risk patients. The patients that are high risk, that have a lot of predisposing conditions, you have to do this, you have to go one step further, with an ultrasound after a spiral CT and maybe the angiogram. Please be careful in high-risk patients. Here it is. So in high-risk patients, if the tests are negative, it's a low probability VQ scan, it's a negative spiral CT, even if it's a negative Doppler ultrasound, go to the angiogram because this will tell you 100% what the story is before you send that patient home. A VQ scan, if it's totally normal, no chance of PE, send that patient home, think about something else. I told you, some people, and you should think about using this, use the ultrasound, maybe you'll find the clot there and you won't have to go to the angiogram, right? So use the ultrasound not only for DVTs, but use them for pulmonary emboli. If you're thinking about pulmonary emboli, because where did the pulmonary emboli come from? It came from the DVT. So look for them. It may save you an angiogram. So let's go back to this case that we started off with. The 32-year-old woman comes to the emergency department with acute shortness of breath and pleuritic chest pain. She takes only oral contraceptives and has no significant history. Her respiratory rate is 26. Her pulse is 107. Her lung and heart exams are unremarkable. Her ABG shows a respiratory alkalosis with hypoxemia and a significant AA gradient. Her chest x-ray is unremarkable, so this patient right away is a high-risk patient, right? So what do you do before you start doing the workup? The answer is, I put this patient on low molecular weight heparin. If they don't give you low molecular weight heparin, then you put the patient on heparin, IV heparin. People don't like it as much because they have to dose it, it's difficult to dose and so forth, but please, they have to be on one of these two things. Then you start the workup. Because this patient is a high-risk patient, you probably should start off with a spiral CAT scan. If it's positive, you stop. It's positive, it's pulmonary embolism, 100%. You bring the patient back and you treat them for pulmonary thromboembolism, which means heparin for at least 5 to 7 days, and then Coumadin for a total of 6 months. And you bridge those two for the first 7 days or so. And we'll talk about the treatment. If it's negative, if the spiral CAT scan is negative, then you say, okay, this is a high-risk patient. Why is she short of breath? Why does she have such a gradient? Why is the chest x-ray normal when she's so hypoxemic? Maybe I'm missing peripheral pulmonary emboli. So then the answer is, what could we do? How could we diagnose him? Maybe we'll do an ultrasound, a Doppler ultrasound. And if we find the clot there, even if the CAT scan is normal, it doesn't matter. If she's got a clot in the proximal veins, this is pulmonary embolism. you treat as pulmonary embolism if she has a clot there. If she doesn't have a clot there on the Doppler ultrasound, then you consider doing an angiogram. It's invasive, but that's the only way you're going to confirm your diagnosis. This is a high-risk patient. Now, in low-risk patients, you could forego some of this stuff, and you could say, okay, let me do a CAT scan, and if that's negative, I'll do the D-dimer and then send the patient home. Or I'll do the D-dimer and it's negative, and plus the Doppler ultrasound. If that's negative, I'll send the patient home. But the high-risk patients, be careful, because the D-dimer in high-risk patients has not been evaluated that much. And remember also, the D-dimer has to be negative. You can't use a positive D-dimer. You could only use a negative D-dimer to exclude disease. So that's the way I would go forward with this patient. So here's a little bit about how to diagnose and how to treat this patient. After we're going to talk about this, but here's a little algorithm that you should have in your mind about a couple things on how we treat thromboembolism. And let me walk you through this figure right here. So this is, look up at the top, it says diagnosed pulmonary embolism, right? So you have diagnosed disease, right? If this patient has diagnosed pulmonary embolism, and follow me to your right here, right? The patient is hemodynamically unstable, right? You use thrombolytic therapy. You see, you go right here like that, okay? Because that's the only way that you could lyse a clot and save the patient. If the patient is hemodynamically unstable, which means heart failure, hypotension, and so forth, that's hemodynamic instability. And then after you give the patient thrombolytic therapy, TPA for example, and you lyse the clot, then you continue with heparin, right, and anticoagulation for 6 months or so forth. It says 3 months here, but it's 6 months now, so forget about that. It's 6 months, everything is 6 months now. If the patient is hemodynamically unstable, anticoagulation is contraindicated. Let's say that's the case because the patient has a recent brain surgery or recent abdominal surgery or recent eye surgery. You can't give the patient thrombolytics, you can't give them anticoagulants. So what you do is give the patient, do what is called a pulmonary embolectomy. They go in and they grab the clot and pull it out. People don't like to use that now, don't like to do that now. They rather use thrombolytic therapy because once you do an embolectomy, this patient has to be on thrombolytic, on anticoagulation for the rest of their lives. But if thrombolytic therapy is contraindicated, this is your only option. And then to prevent further clots, you put an inferior vena cava filter in. That's the only thing that you could do. So hemodynamically unstable patients, think about thrombolytic therapy, and if that's contraindicated, embolectomy. Now on the other side of the coin is about 80–90% of the cases we see that are hemodynamically stable, right here. And what do? These patients, you go right here to heparin. It doesn't have to be IV heparin, it could be low molecular weight heparin, right? And then you bridge that now with anticoagulation of oral anticoagulation, and this continues. Let me say this again. They say 3 months minimum, but I want you to know everything is 6 months minimum right now. Yes, you could have 3 months in some certain cases, but for your boards, this is 6 months right now. What if the patient, though, is stable, hemodynamically stable, but anticoagulation is contraindicated, so you're to the right here, because they've had recent surgery in the eye, recent brain surgery, then you could only do one thing. You could only do inferior vena cava placement here. Remember, they already had one clot. That didn't kill them, so you try to prevent further clotting by using an inferior vena cava filter here. So those are your options, and let's talk a little bit more about these treatment options that we have. We started off with oxygen, right? We always give the patient oxygen right away when they're short of breath. We said that all day today. And then even before they go off to the radiology department, we start with heparin, right? And once we confirm the pulmonary embolism, we continue the heparin, low molecular weight heparin, and at the same time start Coumadin. People like to start both things at the same time. Now, as long as you've confirmed the embolic disease. So you start heparin and Coumadin, and then you continue heparin for 5 to 7 days. Let me say this again. Heparin has to be on board for 5 to 7 days. By that time, your Coumadin should be therapeutic. If it's not therapeutic, then you continue heparin for more. So minimum is 5 to 7 days, or for as long as it takes for the warfarin to be therapeutic, which means the INR has to be therapeutic at least 2. That's a therapeutic INR. And then you continue the Coumadin once you stop the heparin for 6 months. Now, a couple of the complications that we may see and the contraindications, so let me talk about them because we've said them in a different format and I want to explain a couple of things. Once you put the patient on heparin, one of the complications of heparin is this thing called heparin-induced thrombocytopenia. It's an immune phenomenon where you give the patient heparin and they develop antibodies against the platelets and they develop thrombocytopenia. That's one thing that you could get, and you get that 5 to 7 days after you start the heparin, or you could get it right away if the patient has been sensitized to heparin before. And the second thing, the most important thing with these anticoagulants and the heparin is the bleeding. Now, bleeding diathesis is less likely to occur when you use low molecular weight heparin because you know exactly the dose to use. You don't have to, give the unfractionated heparin where you have to dose it with the PTT and have to wait with the PTT and stop it and restart it and so forth. That's difficult to do because the effect of non-fractionated heparin is variable. The fractionated heparin, low molecular weight heparin, you know exactly how much to give. You give it per kg and you know exactly the effect. You don't have to monitor PTT. You don't have to really monitor anything. But these patients are less likely to bleed. That's why we like using low molecular weight heparin now, because it's dosed once or twice a day. In Europe, they dose it once a day at high doses. Here, we dose it at medium doses twice a day. Whatever you like is fine. Most people here in this country will dose it twice a day and then treat the patient 5 to 7 days and then continue the Coumadin on for 6 months. Now, warfarin skin necrosis is a very interesting disease. We don't see that anymore because now we bridge Coumadin and heparin. But in the prior era of using Coumadin, and they would put the patient on Coumadin, and then sometimes the heparin wouldn't be at therapeutic doses. People that have already pre-existing protein C deficiency, remember that Coumadin decreases all the vitamin K factors, 2, 7, 9, and 10. 7 has the shortest half-life, but protein C has an even shorter half-life than factor 7. So really, when you're giving warfarin or Coumadin, any of these Coumadins, you're really causing a hypercoagulable state initially before you decrease 2, 7, 9, and 10. And in that hypercoagulable state is really not significant in most people, except people that have already pre-existing protein C deficiency. Now you cause a very hypercoagulable state by further decreasing protein C, and they develop this warfarin skin necrosis, the diffuse rash with necrosis and so forth. Now, it doesn't happen. If you have heparin on board, it doesn't happen because you keep the patient anticoagulated. But before, we used to have low molecular weight heparin. When you used to dose IV heparin, if it wasn't therapeutic, you could actually theoretically give warfarin to these patients and cause this warfarin skin necrosis. And these are patients with pre-existing protein C deficiency. Contraindications to using heparin and Coumadin are recent major surgery, especially eye, central nervous system. And in these patients, if you can't do it, well, if you can't use anticoagulants, put an IVC filter. We just talked about that already. A couple of things to note further. Some of them we've talked about already, but to make sure everybody understands a couple things. Pregnancy-related thromboembolism is a big deal because pregnant patients commonly develop thromboembolic disease. Pregnancy-related thromboembolism, we can't use Coumadin, right? It's teratogenic. So in these patients, the only thing that we could use is heparin, and the right drug, the best drug to use in this case is low molecular, some form of low molecular weight heparin, because the patient goes home, gets injected once or twice a day with low molecular weight heparin, doesn't have to check PTT, knows exactly how much of the dose to take, and so forth. So pregnancy-related thromboembolism has been saved by the use of low molecular weight heparin. Now these patients stay at home, they get treated with low molecular weight heparin with no problem at all. Thrombolytics are reserved only for the cases of unstable thromboembolic disease. Unstable, I said, means hypotension, heart failure, and so forth, where the patient is really dying and you have to lyse the clot in order to save the patient. Now, heparin derivatives, Coumadin derivatives, they don't lyse the clot. They stop the propagation of the clot. They don't lyse the clot. It's only thrombolytics that lyse the clot. So if you have massive pulmonary embolus and the patient's dying in front of you because of this, the only thing that you could use is use thrombolytics. If a patient is unstable and thrombolytics are contraindicated, then you only have one choice, than to do a thrombectomy. Compression stockings have been used in patients at a risk for thromboembolism to prevent DVTs, and they have been used in the treatment of patients with DVTs because they prevent this associated syndrome with DVTs called the post-thrombotic or post-phlebitic syndrome, where patients, because of big DVTs or recurrent DVTs or maybe even one DVT, develop chronic swelling in the lower extremity. So compression stockings make sure, if they ask you, how do you prevent the chronic swelling associated with DVTs, this thing called the post-phlebitic or post-thrombotic syndrome, the answer is make them use compression stockings for months so you could prevent this. Lifelong anticoagulation, this is lifelong anticoagulation, should be used in patients that had recurrent DVTs and pulmonary emboli, especially people that have thrombophilias. So somebody with protein C deficiency or factor V Leiden deficiency, if these people have had recurrent clots, then you should consider lifelong anticoagulation. Sometimes we can't find the reason for the thrombophilia. So this patient's had 2-3 DVTs, a pulmonary embolus. You should consider lifelong anticoagulation in these patients. Recurrent thrombosis while on anticoagulation is a very interesting scenario, and it occurs in one of two cases. Recurrent thrombosis while on anticoagulation occurs in patients' breakthrough thrombosis. This is referred to as breakthrough thrombosis. While they're on anticoagulation, occurs especially in people with cancer because they have very resistant thrombosis. So they develop thrombosis despite the anticoagulation, and it may occur in some people while on heparin when they develop heparin-induced thrombocytopenia. So let me say this again. People with heparin-induced thrombocytopenia may develop recurrent thrombosis because the heparin-induced thrombocytopenia develops or induces a procoagulant effect. Despite reducing the platelets, for some reason or another, it causes increased risk of thrombosis. So please remember that. That's very important. Heparin-induced thrombocytopenia is not associated so much with bleeding diathesis, but it's associated with hypercoagulability, recurrent or worsening of thrombosis. So let me go back to one of these cases, A 57-year-old man is brought to the emergency department with severe acute onset dyspnea. His respiratory rate is 26, his pulse is 122, his blood pressure is 82/48. Now look at that. It's very low. He's diaphoretic with cold extremities. His lung exam is unremarkable. You have started low molecular weight heparin and Coumadin already. A spiral CAT scan shows a large pulmonary embolus on the left main bronchus. They say, what do you do for this patient? And the answer is maybe consider doing, TPA or thrombolytics, because look, he's diaphoretic, cold extremities, right? And his blood pressure is really low. He's not looking good. So maybe thinking about doing some type of lysis of the clot, TPA, or any of the thrombolytics. This is the right case to think about it. Now these patients are, especially when you put them already on low molecular weight heparin and Coumadin, they're a risk for bleeding. So he's going to be a risk for bleeding when you give him the thrombolytics, but there's really no other way to save this patient. This patient's going to die unless you lyse the clot. The last thing here I'm going to say about this heparin-induced thrombocytopenia that I've told you a little bit about, I want to put it in a nice nutshell for you, because they may ask you a question about this. We've talked a little bit about this already. So it occurs about 5 to 7 days after treatment with heparin. And I told you it may occur earlier if the patient has been sensitized before. Occurs with both low molecular weight heparin and unfractionated heparin. Now, they say, the companies say that it happens less with low molecular weight heparin, but it does happen. It does happen. It probably happens less, but it does happen with both types of heparins. When low molecular weight heparin came out at first, their call to fame was that it didn't cause heparin-induced thrombocytopenia. Now we know it does, probably to a lesser effect. It has a paradoxical effect. Please remember this. It doesn't cause bleeding that much, but it has a paradoxical effect. It causes mostly thrombosis. Mostly thrombosis. So if they tell you somebody has a DVT and it's getting worse, despite heparin and Coumadin, think about this hit. Look at the patient's platelets. Stop all heparin when platelets decrease by 50%, so you don't get this. So watch the patient's platelet level when you put them on heparin. Make sure they're not decreasing. If they're decreasing, stop all the heparin right away. If you need to use other anticoagulants, let's say you haven't gotten to the point where you've anticoagulated the patient adequately and you need some kind of heparin derivative, then there's some new anticoagulants here like lepirudin or agatroban that are heparin-like products that you could treat heparin-induced thrombocytopenia, but make sure you stop all heparin where they're low molecular weight heparins or regular unfractionated heparin. And please also, they may ask us, well, what do you tell the nurses or the house staff and the people that are taking care of the patients? Please make sure, because this is an immune phenomenon, make sure you don't induce, you don't clean the lines or flush the lines even with small amounts of heparin. That the nurses and the residents and the people taking care of the patients sometimes clean the central line. They flush the central lines and the peripheral lines with heparin, and this is enough to sustain the phenomenon because it's immune mediated. All you need is small amounts of heparin to do this. So please watch that. They may ask us a question about heparin-induced thrombocytopenia, and you will definitely see this in the clinical setting. So let's go back and let's do one of these cases, the heparin-induced thrombocytopenia. A 32-year-old woman is being treated for proximal DVT. She's on day 6 of low molecular weight heparin and Coumadin. She reports increasing swelling in her calf and new onset dyspnea. So this is the thing that should set you off. Worsening of the swelling and new onset dyspnea. You're saying, how did that happen? Why would this patient get new onset swelling, worsening of dyspnea? Sounds like worsening of her DVT and a pulmonary embolus, and it is. On physical exam, she's hemodynamically stable, but her respiratory rate is 28. Her lung exam is unremarkable. Her platelets are 35,000 from 220,000. Nobody had looked into that. So what do you do to this patient right away, right? You stop all forms of heparin, continue the Coumadin, and if you need another anticoagulant, now some of these patients, will be already therapeutically anticoagulated on Coumadin, and sometimes you could just continue the Coumadin, But in this patient who's symptomatic, maybe giving some of the newer types of heparins like ergotrapan and stuff like that, it would be appropriate for another week or so until you're sure that you've treated the clot very well. So that's the heparin-induced thrombocytopenia case. After talking about heparin-induced thrombocytopenia, I want to say a little bit about the thrombophilias, these hypercoagulable states that make the patient hypercoagulable and predispose the patient to pulmonary embolism and thrombosis and DVTs and etc. A lot of these have a genetic component to them, so they run in families, and you check the patients you check the family members for the genes that account for the deficiencies. The most important one of these is the one that you really have to remember, because we may get asked on this, is factor V Leiden mutation. Now, I've said a little bit about this before, but the factor V Leiden mutation is very important. It's probably the most common hypercoagulable state, the most common thrombophilia. You may hear that terminology, thrombophilia, from now on. People are using this very commonly. And factor V Leiden is very interesting because it only occurs in people of European descent. If somebody is from full Asian or African descent, it's very uncommon to find it in that. So it's typical European descent. The mutation itself it makes protein C non-active. What you need factor V for is to activate your protein C. And once you have a mutation in factor V, this is factor V Leiden, you are not able to activate your protein C. You have ample amounts of protein C, you have adequate amounts, but it is non-functional. It's really a qualitative problem with protein C. These patients, if you measure their protein C, it's normal. You have to do this thing called the protein C resistance test, where it evaluates the functionality of protein C, and then you make the diagnosis, or what they do now more commonly is to look for this factor V mutation. It's very common that we send away for the gene mutation, and that's the way we diagnose these patients. So there may be a question about that because it's very, very common. Now, somebody that has factor V Leiden may never develop thrombosis in their lifetime, but then at some point he or she may start to smoke. So now it renders them more predisposed. And then something else happens. For example, they get pregnant or they use oral contraceptives. So that's another additive thing. And after this time, now they may start to have thrombosis. So the factor V Leiden may not itself be a predisposition. It is a predisposition, may not be adequate enough to cause thrombosis. Some of these patients develop other things too, some additive insults that make them predisposed to hypercoagulability. Protein C and protein S deficiency and antithrombin 3 deficiency are less common. We see them, but they are less common. Most of these patients, unless they have acquired form of these disease, have thrombosis early on. Early on, I mean at early age, when they're young. So we usually know about them. Remember, these three proteins, protein C, S, and antithrombin 3, are your basic proteins that keep you hypocoagulated. It prevents thrombosis in your body. Protein C is the most important out of the three, but you need all three of these. Now you could get this as a genetic process, where you have a deficiency in one of these proteins since you're born, and you will develop clots early on. But there's also types of acquired deficiencies. So for example, antithrombin 3 acquired deficiency occurs with nephrotic syndrome. Protein S may occur with some other diseases, and so forth. So there are forms of acquired deficiencies of these proteins that you should look for if a patient becomes hypercoagulable. The lupus anticoagulant, you're going to hear about this in rheumatology, is a very important disease as a hypercoagulable state. It usually is called the antiphospholipid antibody syndrome. Please remember that. So after factor V Leiden mutation, that is the second one that they ask us most about. It was called the lupus anticoagulant because it was first noted in a lupus patient. It was called an anticoagulant because these patients were found to have elevated PTTs. So when they looked at the PTT, it was elevated. It looked like this patient would have a bleeding diathesis. But that's not the case. These patients, that is basically the elevation in PTT is basically a lab phenomenon. It's a lab phenomenon because these patients have anti-phospholipid antibodies. We use phospholipids to generate the PTT, and if you have antibodies to these phospholipid, to the phospholipid, your PTT is elevated, but that is not the cause of the disease. It's just a marker of the disease. It's just a lab phenomenon. So really, these patients are hypercoagulable. These are young women that develop spontaneous abortions. They also may be people that don't have lupus, and they develop DVTs. It is one of the rare causes not only of venous DVTs, but arterial DVTs. All the other stuff that we talk about here, usually you develop venous DVTs. The lupus anticoagulant, or better said, the antiphospholipid antibody syndrome, is probably the one that you got to know that may cause venous DVTs, but also may cause arterial thrombosis. So if they ask you, does any hypercoagulability state cause arterial thrombosis, the answer is the antiphospholipid antibody syndrome. These patients also have a false RPR, false positive RPR, a false positive VDRL, same thing. So sometimes you hear the terminology here, anticardiolipin antibody syndrome. So lupus anticoagulant, anticardiolipin antibody syndrome, antiphospholipid antibody syndrome, this is one and the same disease. Even though we saw it first in a lupus patient, and that's why it was called the lupus anticoagulant, most of these patients don't have systemic lupus. They have nothing. They just have the hypercoagulable state. So please look for that. That may be a question that they ask us about the antiphospholipid antibody syndrome. Watch it because the PTT is elevated, but that's not really what's wrong with the patient. That's just a marker of the disease. It's a lab phenomenon. Also, be careful because these patients have spontaneous abortions. So they ask you, could you have an elevated PTT and have a hypercoagulable state? Yes, this is it. They don't bleed, really. They clot. And the lupus anticoagulant, the antiphospholipid antibody syndrome, arterial clots, arterial thrombosis. The other two is some of the last two here, the hyperhomocystinemia and prothrombin mutations, some of the newer ones that have come out over the last couple of years that people are really looking into now, and they seem to be coming up and will be important in the next couple of years. So these are the 5, 6, 7 diseases that you need to keep in mind in terms of hypercoagulable states. The factor V Leiden mutation is the most important one. Then think about things like protein CS and CS and antithrombin 3 deficiency, and then I definitely need you to know the lupus anticoagulant and just a little bit about the other ones that they exist as entities. I want to talk more now on a little bit about pregnancy and thrombosis. So why are pregnant patients prone to thrombi, to thromboembolic disease? They've asked us a couple questions about that. We all know that there is a predisposition. So the thrombogenic potential of really pre-existing diseases increases in this case. That's what I want to make clear to you. So patients that are pregnant and have thrombosis usually have pre-existing diseases. That's very important that you understand that most of these patients don't clot just out of the blue. They usually have some kind of pre-existing potential disease. So plus, because on top of this, a couple of pregnancy-related changes occur. So for example, studies have shown that the resistance to protein C increases. It just happens in pregnancy. We don't know why, but it happens. Protein S activity decreases. And then some other things, like fibrinogen increase, so they make you more prone to clotting. Most of the patients will develop DVTs or pulmonary emboli. But sometimes these patients, especially in diseases like the antiphospholipid antibody syndrome, the lupus anticoagulant, one of the common presentations of a hypercoagulable state of a thrombophilia is that the patient presents with recurrent fetal loss or stillbirth probably has to do with placental infarcts from the hypercoagulable state. So please, if you hear that this patient, especially after the second trimester, is having fetal loss, and it's happened more than a couple of times, and stillbirths are common in this patient, especially if you get a family history that has happened to somebody in the family, again, please start to work them up for hypercoagulability. The most common things are the ones that you're going to look for first. Things like factor V Leiden mutation, things like antiphospholipid antibody syndrome, and so forth, because these are the most common ones. If you find one of those, then the way to treat the patient is to use heparin, low molecular weight heparin, throughout the pregnancy. And that prevents the fetal loss and the stillbirth. These are just manifestations, really, of the hypercoagulable state. So low molecular weight heparin, right, in a patient that has recurrent thrombosis once you diagnose some type of thrombophilia. The last thing here I want to talk about is a type of an embolism. They don't ask us many times about this, but I've heard that sometimes you could get a question about this. This is not the conventional embolic disease. This is fat embolism, and it typically occurs about 3 to 4 days after long bone fractures. So you're usually going to get somebody after some kind of trauma. Some kind of trauma, the bigger the trauma, the more extensive the trauma, the more likely you're to get the fat embolism. Now, there have been cases that have been done after chest compression, severe chest compression, CPR. They're trying to save the patient, and they've broken a long bone or a chest bone, and you may get fat embolism from that. It's rare. So 99% of the time you're going to see them after an extensive trauma, usually in an older individual. It presents about 3-4 days later, and what you get 3-4 days later after the long bone fracture, maybe even after they've taken care of the fracture, the orthopods, you develop acute dyspnea, just like a thrombosis, shortness of breath, and then over the neck area and the axilla, from the fat embolus, you get petechiae. Petechiae. So over the area, the axilla, the neck, big petechiae like hematomas, and then the patient gets confused. So that's the triad. Confusion, altered mental status, petechiae in the neck and axilla area. Make sure they don't show you a picture of that. Somebody after a car accident developed this, and dyspnea. That's the triad. What do? The treatment is not anticoagulation. This is not treated like pulmonary embolism. So we don't give anticoagulation. Some people say it's probably contraindicated. Most people do just supportive care. They give the patient oxygen. Some people, they question maybe the use of steroids, but this is not conventional. Not everybody uses that. So maybe steroids, but mostly all people do is give supportive care and kind of make sure that the patient is, gets through this as much as they can. And we don't give anticoagulation. This is not an area where you want to use heparin and Coumadin. And that concludes our chapter on pulmonary thromboembolic disease.